Good afternoon, and thanks for joining us for today's brand new Healthline 3. I'm your host, Courtney Butts, and Healthline 3 is where we like to focus on ways to live a healthier, happier, and pain-free life. We'll be taking your calls and answering your questions right here live in the studio today. We'll be opening those phone lines soon, but as a reminder, make sure you're in a quiet room when you call with your TV turned all the way down so we can hear your question. That number to call will be on your screen, but it's 318-219-4569. And today we are talking all about peripheral vascular disease. And joining me today to talk about this is Dr. Britton Eaves, with your cardiologist at Willis-Knighton Cardiology.
I am.
Thanks for joining us.
Thank you. Thanks for having me.
Absolutely. So peripheral vascular disease is not really a disease you hear about a lot, I would say. So give me a brief overview of what it is.
Okay. Well, peripheral vascular disease encompasses the diseases of the arterial system as well as the venous system. It's estimated that about 20 million Americans have peripheral vascular disease. In addition to that, about as many as 2 million people have critical limb ischemia. When I talk about critical limb ischemia, that means that the perfusion to a limb is so poor that the patient is at risk for amputation. Unfortunately, there are still a large amount of amputations being done, and the consequences of having an amputation are very severe because typically these people are older. That if you have a below-the-knee amputation, the chance of being fitted with a prosthesis and going back to ambulating is 50%, 20% above the knee. A lot of those people end up going after their amputation, going to nursing home. Quality of life is not good, and does carry significant morbidity and mortality risk as well.
Yeah, okay. And you mentioned in our midday newscast that it's one of the diseases that are sometimes asymptomatic for a long time.
You'd be surprised. So classically, as you mentioned, I think when we were talking off the air, that the symptoms classically would be somebody that, let's say when they walk, their calves got tight or kind of burned, or they felt fatigued and had to stop and rest until it got better. But a large amount of people actually are fairly asymptomatic. That can be due to a number of reasons we really don't have time to go into here, but a lot of times they are symptomatic, but they attribute their problem to, oh, I'm just getting older, I'm slowing down, or I have arthritis, or things like that, and so they don't get diagnosed.
Right, okay. And so what is the main cause, or how do people, what kind of culminates into this diagnosis of peripheral?
Well, we can kind of separate the arterial from the venous. The arterial problems are essentially the same as cardiovascular risk factors, which most people are familiar with. The number one cause would be diabetes. Diabetes is a terrible, terrible, devastating disease, and so that's the number one cause. The number two cause, which that one is preventable, and that's smoking, and then of course other factors such as high lipids and cholesterol rather, and what was I trying to say? High lipids. Anyway,
there's a lot of lifestyle factors as well.
Yeah, just the normal lack of exercise, and not eating the proper foods, and so on and so forth.
Yeah.
But it's basically the same risk factors that would put you at risk for developing heart disease are the same risk factors that put you at risk for developing peripheral arterial disease. And so a lot of those you can modify. You can get your cholesterol under control. You can have your high blood pressure treated. You can certainly get diabetes treated if you have that. And then also an awareness to be evaluated for it. And if you have any of those kind of symptoms where you're not able to walk like you used to, and so forth. Now, venous disease, multitudes of things. Anybody's at risk for developing a blood clot in their vein. If you go on a long, say, an international flight, sometimes people who are truck drivers that go on long hauls, they're at risk. If anybody's on a long haul car ride, so mobility, trauma, we see it a lot of times after surgery. People laying in the bed for recovering from surgery develop blood clots, and used to, even as soon as say 10 years ago for sure, we just put those patients on blood thinners, and if the clot was above the knee, only 50% of them had a significant resolution of their clot, and they were left with sort of debilitating symptoms of swelling and so forth. But now we have technologies that can actually extract the clot.
Oh, wow.
And there's some other anatomical stuff. Again, you know, we could talk for hours about this. We don't have time today, but you can actually have compression of the vein from crossover from the artery. We can stent those and we can treat that. People also suffer from superficial venous insufficiency where they have the varicose veins and things like that, and those can be stripped and treated as well. So technology has really caught up with the disease. So.
Cool. Yeah, okay, and so quick anatomy lesson if you want to share with us.
Okay, sure.
You know, your arteries versus your veins. You know, your heart's a well-oiled machine for your body, but kind of explain maybe the differences between the arteries and the veins.
Okay, well the arteries are, of course, they handle the pressure that comes from the heart. That's where you measure your blood pressure. So they're a high pressure circulation system, and their job, in a nutshell, obviously much more things they do. They supply nutrients and things like that. But one of the primary jobs is to supply oxygen to the cells so that they can metabolize and do whatever function that they're designed to do. So when you have an obstruction there, of course, there's decreased perfusion, and if it's bad enough, you can actually have tissue breakdown to where you have wounds on the feet and so forth that won't heal. And this many times is what leads to someone in a crisis where they're faced with, if they don't restore circulation, they end up with an amputation.
Gotcha, okay. And then conversely, the veins, they have another job, right?
So the veins' job is to return blood to the heart. And they're thin-walled, they are anatomically quite different than arteries. And as I said before, sometimes people, the big artery that comes from the heart, the aorta, is on the left side, and the big vein that returns blood to the heart is on the right side. But down about the level of the belly button, they have to cross over to bring blood and return blood from each lower extremity. And when it does that, the artery can actually compress the vein, and so that can cause intermittent swelling or even blood clots, and that can be treated with stenting. Also, there is much larger than people would probably suspect. There are subsegments of the population that actually have clotting disorders, and they can be asymptomatic for years, and that can cause people to have blood clots.
Right, yeah, so all the time people think, okay, I got to keep my heart in shape, but also it's equally important to focus on the plumbing as well.
Oh,
you know,
for
make
sure, for sure.
It's all good. Okay, so our phone lines are open, and you've got that number right there on your screen, 318-219-4569. Give us a call. We've got Dr. Britton Eaves here with Willis-Knighton Cardiology, and we're talking about peripheral vascular disease and the symptoms that are associated with that, who's at risk, and all that good stuff. So we'd love to hear from you. So who typically is that person or that candidate that's at risk for this disease?
Well, all of us are at risk because, as I said before, you know, without you know, the usual things that we should be doing to take care of ourselves, we all potentially are at risk for developing diabetes at some point in our life. Certainly, smoking can lead to that, uncontrolled hypertension, and unfortunately, a big problem as well is folks that end up with renal insufficiency or kidney failure bad enough that they have to go on long-term dialysis. Unfortunately, those people develop something we call secondary hyperparathyroidism, and so they have a disorder in managing their calcium, and so they tend to really develop a lot of calcifications in the artery. We do have a lot of new technologies to treat those, but that's I really feel like that's something that in the future medicine continually advances, and I think on those patients, if we can find the key to better help them manage their calcium, that might be a way to prevent or lessen the impact of some of the disease on them. But anybody potentially is at risk. And it's important to know too that, you know, you say, well, if most of the people, majority of the people actually, quote, asymptomatic, why are we rushing out to treat these things?
Right, yeah.
Well, it carries a significant morbidity and mortality rate. Even people with what classically been described as sort of mild to moderate Once they get into that moderate range, and there's a simple test that the doctor can do, and it's a screening test. We simply measure the pressure in the arm, and we measure the pressure in the ankle, and we divide the ankle pressure by the arm pressure. So if we don't have any obstruction from here to here, it should be 1. It should be the same. And so as that number decreases, that implies the severity of the obstruction.
Right.
So when we get down to a level of 0.8, which in the past was described as mild to moderate claudication, those patients actually have the prognosis of a woman who has a new diagnosis of breast cancer.
Oh, wow.
Which is really crazy. And once it gets down to a level about 0.4, which is severe, and most of those people have, they kind of claudicate all the time. You know, I have some really sad stories. I've had people that actually had to sleep with their leg hanging off the side of the bed because they needed that extra pull of gravity to get enough blood in there. That's the only way they could get some relief. But those patients, once you get down to that level, their 5-year survival approaches are, it's actually about the same as colon cancer, believe it or not, and is approaching the prognosis for lung cancer.
Okay. So you said claudicate. Can you explain what
So
that means?
I'm sorry, claudication just simply, you know, if you really want to do a deep dive, it comes from I think the Claudius, one of the Roman emperors, and they said he had a limp, and we're not sure if he had peripheral vascular disease, but anyway, so that's where the term came from. But what it means is pain or fatigue or sort of loss of muscle function with exertion. If you think about the muscles, when the activity increases, they need more oxygen. So it's really a oxygen demand supply mismatch.
Gotcha. Very interesting. And so that kind of causes those symptoms that you would associate with peripheral vascular disease, of the pain in the legs, the aches maybe in the calves that you mentioned. So when should someone worry? Let's say maybe they have arthritis and they're not sure, do I have peripheral vascular disease or is it just my arthritis, like we mentioned earlier? What are ways to do that? Maybe just see a cardiologist?
Well, I mean, it's a multidisciplinary approach, really, is how it should be. And so your primary care doctor is a good place to start. First off, your primary care doctor is going to be the one that's helping modify your modifiable risk factors, and that's control of your hypertension, control of your diabetes, weight loss, smoking cessation, all those things. And a basic way is just to check and see if they can feel the pulses on your feet. And if they don't have time for that, they certainly can send them to us. We can do a ultrasound or do the tests that I talked about before, the ankle brachial index, which is, I mean, that's just a matter of taking a blood pressure here and a blood pressure there, and it's pretty accurate. Sometimes it can be falsely elevated with calcium, but again, that's kind of an aside. But
Okay. And so is swelling also associated with this?
Swelling is usually associated with venous insufficiency because, again, with arterial, there's a deficit of bringing blood into an extremity, so it's difficult for it to swell. A classic presentation of somebody that has pretty significant peripheral vascular disease would be, peripheral arterial disease, excuse me, would be loss of pulses, where you can't feel the pulses on the foot. Extremity would tend to be cool, sometimes severe. In men, you might actually have loss of hair on the extremity because there's not enough perfusion there, and then wounds and so forth. And one of the saddest things I see a lot of times, I know even as a physician, I'm sometimes very hard-headed about, you know, oh, it'll be fine, I'll get over it, and it's, you know, we tend to be a little stoic and just press on with our lives. But many times I see people come in and they've got this horrific wound on their toe or something like that. And how long has this been here? Weeks, and it's in a mess. And the thing that I would like to really strike home on that, people don't realize that that might be the marker. If you have even a small wound, say on your toe, big great toe, small toe, wherever, that may be a marker for underlying severe peripheral vascular disease. If it's not healing, people don't appreciate that if it's not healing and it's not taken care of, it actually could result in loss of a limb. And so it's better to, I would encourage anybody that is maybe seeing home health wound care for a non-healing wound to be referred for a evaluation of their arterial blood supply. Because we restore blood flow to that wound will heal and that limb will be saved. I mean, that's sort of my main focus, is to try to keep people from losing their limbs. I mean, because it goes way beyond the medical aspects, as you could well imagine. It's very devastating to lose an extremity. And on top of that, you lose mobility, and your quality of life suffers because of that. And then, of course, we're designed to be upright, mobile creatures, and the more you sit, the more you have to lay in the bed. You just put at risk for all other things. And then the other thing, again, I'll just reiterate, is if you have peripheral vascular disease, you have a fair chance that you also have significant coronary disease or carotid disease, which is, can lead to strokes and things like that.
Right, okay. And typically, so this might be a funny question, but can you also have peripheral vascular disease at the same time that you have peripheral arterial disease?
Oh, for sure. You can have venous and arterial, yeah, for sure. Okay,
because similar risk factors, I'm sure, and yeah, okay. Very interesting. So let's talk about some treatment options.
Okay.
So we've talked about maybe all the scary things to look for, but how, is this something that we can maybe, like somebody's having severe pain in their legs, can that pain be reversed or taken care of through treatment?
Absolutely, and that's I worked hard to get here, school and everything, and I'm blessed that I make a good living, but absolutely the most gratifying thing I do is to have a patient come in that they have to stop when they walk to their mailbox because their leg hurts, and when you restore blood flow, you just know, I tell them all the time, you're going to have a good weekend.
Yeah.
I mean, you've really impacted, so I'm very gratified to be able to be a part of that.
Yeah.
But yeah, we have all kind of great, the field in the treatment of peripheral vascular disease is just really, over the last 10 years, just really exploded. So I have all kind of crazy fun toys. I have lasers and devices that spin at 150,000 or 180,000 RPMs. We have suction devices, drug-coated stents, drug-coated balloons, all kind of things. Matter of fact, on Wednesdays, which was yesterday, was my leg day, and had a guy that had a completely occluded blood vessel behind his knee that he'd been trying to get fixed for a while. We fixed that yesterday. It's very gratifying. Had a fairly young woman that had her entire iliac, which is the division off the aorta that feeds her. It fed the entire lower extremity, was 100% blocked from here to here. Got that opened up. There's a lot of things that we can do.
Yeah.
So, like I tell patients, we're certainly not God, but we are able to save the vast majority. In fact, I sort of make it feel like a sort of a failure. I'm hanging on to that extremity to the bitter end. And also we have some great stories too, where people have actually been scheduled for an amputation and came and saw me, and we saved their leg. And that's I saw this one patient not too long ago. The day that I did the first procedure on her, she canceled her appointment to go and have her leg amputated, and that was about 7 years ago.
Oh wow! Oh my gosh! And still has the leg. And
still ambulating.
That's awesome. So for example, your two most maybe common things are getting rid of that clot, or using a balloon to maybe open it, or
we
extracting
have balloons
it.
and stents and suction devices that remove the clot and so forth. The other thing that's really come a long way, that was a huge cause of mortality for post-op patients particularly, was pulmonary embolism, and that's where you have a large clot that usually begins in the leg from trauma or immobility or things like that, and then it just suddenly is able to migrate, and it goes up into the lungs, and it can completely obstruct the blood flow into the lungs. And unfortunately, wasn't common, but it wasn't uncommon to have the rare patient, you're about to send them home from surgery and they had a blood clot. And so anyway, so now we have pulmonary embolism, and we do a lot of them at Willis-Knighton. They do them at all three of the camps. They do them at Piermont, Bossier, and North, and that's been very gratifying as well, because again, just like when I mentioned the blood clot, in the past, before we had these devices, we just put the patient on blood thinner and hope for the best. But now we have actual treatments to
actually
treat it.
see that difference.
Oh, it's very gratifying to see somebody in dire straits, distress, do the procedure, and then come see them the next day, and they're ready to go home. That's very gratifying.
Yeah, okay. And so when you're maybe just specifically talking about the legs, are these minimally invasive procedures?
Well, minimally invasive in that it's all done, we call it endovascular, which means we go through the vascular system.
Okay.
You know, we're sneaky like that. You know, when I first started off, we had sort of a, we have a very great relationship now with our vascular surgery community, and I said multidisciplinary. When I first started off, it was kind of a little turf war. They didn't really know, you know, had these cardiologists that were dabbling in, you know, this is not a heart, what are you guys doing? But now everybody does, because, you know, it's, as you said, it's less invasive, there's less potential morbidity, mortality, and there's so much that can be done. You know, we can put stents in for aortic aneurysms, which before was a major surgery. We can do that through the legs. And I have colleagues over at the North Campus that actually replace valves through the arterial system, and they do what's called structural heart. They close up areas of it's called a foraminal valley that separates the two atrium that can be a cause of stroke. They're able to do that through the arterial system. So I mean, technology is really
that's awesome. So let's say after a procedure, what is maybe the risk of something like that clot coming back?
Well, it's hard to say. You know, it's hard to say in general because every patient is a little bit different. You know, some of the so for the arterial side, clot usually is caused by an obstruction, and so there's decreased blood flow, and so it clots. So when you fix the obstruction, usually that's taken care of. Now, as far as the venous side, sometimes the veins are damaged, and some patients may have coagulopathy or a disorder that needs to be treated. But so it varies from patient to patient. But typically, you know, once we've made the diagnosis, then we treat the problem. Then of course we surveil them and do other, you know, try to modify risk factors and medication to prevent them from having further episodes. So.
Gotcha. Okay. Very interesting. Well, we have just a couple minutes left, and if you're just joining us and you have a question for Dr. Eaves here, who's a cardiologist with Willis-Knighton Cardiology, give us a call at 318-219-4569. Okay, so you know, we talked about the treatment, we've talked about risk factors. So let's say someone maybe has been diagnosed and they're not maybe to the point of surgery yet. Are there things that they can do, maybe exercises or other things that are, you know, less invasive or less surgical or that they can do?
Well, back when I first started medical school, because that's all we had, they would recommend, because surgery was the only thing that could be done. And at that time, it was a pretty major surgery. It was a bypass surgery, usually requiring opening up the abdominal cavity. And so they would talk about, you know, exercising that caused decreased blood flow. You know, good Lord didn't make junk. You know, the life is amazing. Organisms, human beings are amazing. So if you exercise, you actually will stimulate the formation of collaterals. But that's sort of a inadequate. You know, I wouldn't put that as a viable strategy versus getting diagnosed and getting treated.
Yeah. Okay.
Because we really can make a huge difference.
Okay. And so if someone knows that they've been diagnosed and maybe their symptoms aren't getting any better, how hard is that process, or how easy is the process to maybe get in and have that procedure done?
Well, we try to make it absolutely as easy as possible, so it would just be a matter of you know, contacting the office or getting the primary care to contact us. You know, I actually, you know, I mentioned before multidisciplinary. I get a lot of referrals from wound centers. You know, patients going in, they have a wound that's not healing, and so the wound doctor will send them to me, and we'll get the ultrasound, and so that's a win-win for the wound care guy, win-win for me, and certainly win-win for the patient. So once the blood flow is restored, then the wound guy can go ahead, or wound gal, whoever, can continue the therapy, and the wound heals, patient's happy, and so.
Yeah. So after the procedure, how soon are people back to doing their activities? That
I
they would
send
like?
most of my people home the same day.
Okay, nice. So this
We
is
have closure devices, so it's through the vascular system, and then afterwards, majority of the time I use a closure device that actually will close it right up, and then we watch them for a couple hours and send them home.
And are you doing this, you said vascularly, so do you have like something where you can see, you know, like everything's so advanced now, you know, everybody's using robots. Do you have like a robot that you use?
No,
or like
not so far. It's a
screen?
little, there's so much, eventually I'm quite sure, you know,
Yeah,
a robot
right.
will take my job. But it's kind of interesting. So we work, I think the best way to describe it is a gamer would do
Okay.
pretty well, because what you're looking at a live fluoroscopy screen, and you have, you're down at the groin or the arm, and you have a very small wire. It's 0.04. It's about the size of, I don't know, about 4 or 5 human hairs if they were bound together. It's a pretty small wire.
Okay.
And so, and then you have the catheter. The wire, you get the wire past the blockage, and the wire is like the monorail at Disney World. You know, so the train goes on there. So once the monorail is there, whatever you put goes where the wire goes.
Okay.
And so you sit there and you watch the monitor, and you can push, you can pull, you can rotate clockwise, counterclockwise, and that's pretty much it. So you have to, it's a little
Okay.
dance that you do, you know.
And start to finish, I'm sure every procedure is different.
Everyone is
Yeah.
different. I mean, it might be a 30-minute procedure, but we've all had procedures that have been hours, you know, even 4, 5, 6 hours and so forth.
Yeah.
I know my crews sometimes get frustrated, but I hate to be defeated, you know, and it is important to try to get the best outcome for the patient. So it just varies.
For sure, yeah. So if someone's at home and they have an upcoming procedure like this, what is there anything they can do to prepare or get ready for it?
Not anything in particular per se. We usually
Okay.
try to give them good instructions ahead
Yeah.
of time and so forth.
Yeah. So
But-
nothing to be nervous about, and
No, anticipation is the worst part of anything, for sure.
is
So
it? Are you under anesthesia usually
So-
for this?
the great thing about it too, because it's endovascular rather than surgical, we don't, quote, put people to sleep.
Okay.
Now that does not mean that they don't fall asleep. We call it monitored anesthesia.
Okay.
And I make every attempt to make the patient as comfortable as possible.
Yeah.
So we give them continual pain meds and some anxiolytic, like you know, to calm their nerves. So most of the time, my goal is to have people fall asleep during the procedure.
Okay.
My main goal would, when we're done, have the patient say, "I didn't even know y'all got started."
Exactly,
So
yeah.
that's the goal. But
Awesome.
it doesn't require being put to sleep, which, you know,
Yeah.
people are sometimes very
Reserved,
uncomfortable
yeah.
and afraid of that. So we don't, quote, put people to sleep. When we talk about, from a medical standpoint, when we talk about putting people to sleep, we usually mean that we put them on the breather machine like you have done when you have major surgery.
Right. Okay. So where can we find you if someone at home is interested in getting established with your care? Where can they find you?
Well, I'm with Willis-Knighton Cardiology. My primary campus is at Willis-Knighton Bossier. I do have partners that do this types of procedures over at Willis-Knighton North, and another group, Piermont Cardiology, over at Piermont. Some of those guys do it over there as well.
Okay.
But also too, if you're seeing a podiatrist with a wound, again, I get a lot of patients from them. They're seeing them for something else, and they just haven't noticed, I don't really feel a good pulse.
Right.
And they'll, because we've worked together for years. I got started doing this back in 2000. I don't know, I've been doing it for
a while.
good long time, 15, 20
awesome.
years, something like that. And so it's really grown over time.
Yeah, exactly.
But
Well,
just being aware, cool extremities, lack of
Yes,
pulse,
exactly.
fatigue, tiredness when you walk. And for sure, if you have
Yes.
a wound on
Thank
your
you for
foot,
joining
sorry.
us.